but most of it's going to be bedside. I'm going to talk about our work in developing a targeted treatment for metastatic prostate cancer. I'm going to focus on our efforts with a radio-labeled antibody, but as you will see, it goes beyond that. The central premise of my group's focus is pretty simple and pretty straightforward. It is the premise that if one has the ability to specifically target cancer cells in vivo to the exclusion of normal cells, that provides a very powerful platform from which one can develop diagnostics and therapeutics that have a significant potential to improve the care of patients, cancer patients and otherwise. These are the three subjects I'm going to talk about in the next several minutes. Firstly, why prostate cancer happens to be an ideal clinical setting for antibody-based therapy. Secondly, what makes the molecule known as prostate-specific membrane antigen a really ideal target. And lastly, I'm going to give you some of our some of our bedside clinical data to exemplify that. Okay, so first topic, what makes prostate cancer an ideal clinical setting? Well, first of all, prostate cancer metastasizes predominantly to bone marrow and lymph nodes. These are organs that get very high levels of circulating antibody. In addition, for the vast majority of the natural history of prostate cancer, one is dealing with small volume metastatic sites in the bone marrow and also in the lymph nodes. And this is a setting which is particularly appropriate for antigen access or antibody penetration. In addition, in prostate cancer, we can very readily identify which patients have microscopic disease volumes, much better than in any other solid tumor. And the reason for this is primarily because serum prostate-specific antigen, which you may have heard of, is clearly the best blood biomarker in the cancer field currently available. And because patients tend to have a rise in their PSA generally years before they show any sign of frank metastatic disease, so merely by looking at a patient's PSA, we can determine when they are beginning to fail from their local therapy, and we can discern that years before they have clear-cut evidence of metastatic disease. And we can take that one step further, because there are now a number of validated instruments available that allow you to, in essence, quantitate the level of a patient's risk even before he has an elevated PSA. So we can treat patients at a time when they have infinitesimally small burdens of disease, again, unique in the solid tumor field. And lastly, because PSA does represent a reasonable surrogate marker, we can very quickly evaluate the anti-tumor activity of various agents in phase 1 and phase 2 trials by looking at changes in PSA. Moving on to prostate-specific membrane antigen. Probably many of you are not familiar with this particular target. It is pretty well understood at this point. There are some things that we don't understand, but there are now over 1,000 papers in the literature on PSMA. And the nitty-gritty is, and what's relevant for my discussion today, is the fact that PSMA is the single most well-established prostate-restricted cell surface membrane antigen known, period. The gene's been cloned, it's been sequenced, and it's been mapped. The crystal structure of PSMA has been determined. And I want to make sure you understand that PSMA is different from PSA or PAP, PAP being prostatic acid phosphatase. These are the two earlier markers for prostate cancer. The difference being that unlike PSA or PAP, which are secreted antigens into the patient's blood, PSMA is an integral membrane protein that is not secreted. Other benefits of the PSMA target is that virtually all prostate cancers are PSMA positive. So you've heard a little bit today from some of the previous speakers about breast cancer as an example. There was probably some talk about the use of Herceptin, an antibody to HER2. By comparison, the HER2 antigen is expressed in roughly 20, maybe 25% of breast cancer patients. Conversely, in prostate cancer, virtually every prostate cancer is PSMA positive. In addition, PSMA is highly prostate cancer specific. In fact, in vivo, when one uses an antibody for all intents and purposes, and you'll see some of this graphically demonstrated, PSMA is operationally completely prostate cancer specific. In addition, it's expressed at very high levels on the cell membrane. And this allows us to target a lot of antibody or antibody drug or antibody radioisotope to the tumor sites. And just by way of comparison, again, there are a number of antibodies, as you may know, that are already approved for the treatment of various cancers. In the case of PSMA, it's expressed at levels on the cell surface that are exponentially higher than what you see with those other target antigens that have already proven successful. In addition, it's been shown by a number of groups that as the PSMA level increases in prostate cancers, those cancers tend to be more biologically aggressive. So when we target a modality to PSMA, a treatment modality to PSMA, we actually have better ability to target the worst prostate cancers. Also working to our benefit serendipitously is the fact that when one treats a prostate cancer patient with hormonal therapy, which has been the mainstay of treatment for patients with metastatic prostate cancer for almost 70 years now, the amount of PSMA on the cell surface increases by tenfold. Last but not least on this slide is the fact that PSMA happens to be rapidly internalized, and this allows us to put drugs on the antibody, nanoparticles on the antibody, radioisotopes on the antibody, a myriad of different things. And when we administer those payload conjugated antibodies to a patient, we can deliver that payload directly into the tumor cells without targeting normal cells.